Consistent with the fact that asthma is an obstructive lung disease, when we perform pulmonary function tests or PFTs, our asthmatic patients are going to have an obstructive pattern, namely that they will have a decrease in their expiratory flow rate, a decrease in their FEV1, and the FEV1 decrease will be more pronounced than the decrease in their forced vital capacity or FVC, thus resulting in a decreased FEV1 to FVC ratio. And this can be further appreciated in our schematic on the right-hand side of the presentation, where we can see the patient's volume exhaled compared against time. And as we can clearly see, the FEV1 in the case of obstructive diseases is significantly decreased compared to our normal patients or restrictive disease counterparts. This decrease in the FEV1 and the patient's inability to essentially blow air out is also reflected in the flow volume curve that we classically see on examinations. As you can see, if we look at the y-axis here, when we go above the x-axis, this is going to refer to expiration, and when we go below the x-axis, this is going to refer to inspiration as we move towards more negative numbers. This flow volume curve, as we can see, is classic for a patient with asthma or of obstructive lung diseases more generally, as we can see that this patient clearly has a more difficult time when it comes to exhalation. Rather than having a nice smooth outward flowing of air, the patient has an obstruction, thus causing this to slope downward in this concave fashion. And this is highly characteristic of the flow volume curve that we would expect to see in our asthmatic patients. Also related to this pronounced decrease in the patient's FEV1, we can also use a tool called a peak expiratory flow rate, or peak flow, in order to monitor our patient's disease course in the case of asthma. It should also be noted that the use of a peak flow using a peak flow meter, as pictured at the bottom of the presentation, is the fastest way to diagnose asthma. This makes the use of the peak flow meter ideal for emergency department and acute settings. And additionally, the peak flow meter can be used in the case of patients with moderate to severe asthmatics on a daily basis in order to monitor the course of their disease. And although the use of spirometry and full-blown pulmonary function testing is preferred in order to get the most accurate diagnosis of asthma, the peak flow meter can still be extremely helpful in that it allows our patients to have a more portable way of assessing what is essentially a proxy for their FEV1 value, thus allowing the patient to monitor the severity of their disease course over time. As we have stated previously, the key triad which underlies the pathophysiology of asthma includes airway inflammation, airway hyperresponsiveness, and very high yield to keep in mind, reversible airflow obstruction. This reversibility of the airflow obstruction is something that we actually utilize in clinical practice, as we can perform spirometry in our asthmatic patients before and after administering a bronchodilator. This can be done in the clinic by assessing a patient's pulmonary function tests before and after giving a beta-2 agonist, for example, albuterol. The key cutoff to keep in mind for this is that if the patient's FEV1 or FVC increases by at least 12%, then that patient is said to have reversible airflow obstruction, which is highly suggestive of asthma. Other additional testing that we can perform in confirming a diagnosis of asthma includes bronchoprovocation testing, with broncho here referring to the bronchi and provocation referring to provoking this disease. This bronchoprovocation testing is utilized when asthma is heavily suspected, but pulmonary function testing is non-diagnostic. The most common way of performing bronchoprovocation testing is with the use of a methacholine challenge, methacholine being a cholinergic agent, which leads to bronchoconstriction. In a methacholine challenge, we are able to assess the patient's PFTs before and after inhaling increasing doses of methacholine. And as would be suspected in the case of asthmatic patients, the pulmonary function tests are going to become more obstructive in terms of their pattern at lower doses compared to normal patients. Additionally, if there is at least a 20% decrease in the FEV1 in response to the methacholine challenge, and this is considered to be diagnostic for asthma. In addition to these variations on pulmonary function testing, we will also sometimes obtain a chest X-ray in patients with asthma. This is typically reserved, however, for severe cases, especially in the context of acute exacerbations, and this is performed in order to rule out pneumonia and pneumothoraces. And as we see in the case of other obstructive lung diseases, in the case of severe and long-standing asthma, we may see hyperinflation of the lungs on this chest X-ray.